Patients started dying at exactly 3:17 a.m. every night. The hospital staff thought it was just a coincidence. But Nurse Helena Nightshade knew better. She had been setting her watch to that exact time for 3 years. What the families didn't know was that their loved ones weren't dying from their illnesses. They were dying from mercy. Let us know where you're watching from and what time it is for you in the comments. It's always fascinating to see who's joining us from all corners of the world. Now dim the lights, maybe turn on a fan for that soft hum in the background. And let's begin our journey together tonight. The fluorescent lights of St. Catherine's Hospital cast their cold, sterile glow across the polished floors as Helena Nightshade made her rounds through the terminal ward. Her white uniform was pristine, not a wrinkle out of place, and her silver hair was pulled back in a perfect bun that had become her signature look over her 15-year career. To the casual observer, she was the embodiment of professional nursing, competent, caring, and utterly dedicated to her patients' well-being. Helena had specifically requested the night shift 3 years ago, claiming she found it more peaceful and conducive to providing quality care. The hospital administrators had been delighted to accommodate her request, as finding nurses willing to work the graveyard shift in the terminal ward was notoriously difficult. What they didn't understand was that Helena had discovered her true calling in these quiet, darkened halls. The night shift provided the perfect cover for her work: fewer witnesses, less supervision, and patients who were often alone with their fears and pain. It was during these vulnerable hours that Helena could practice what she privately called her art of mercy. Tonight's subject was Mrs. Eleanor Pemberton, a 73-year-old woman suffering from advanced pancreatic cancer. The poor woman had been writhing in agony for weeks, despite the strongest pain medications the hospital could legally administer. Her daughter visited daily, holding her mother's hand and whispering prayers that seemed to go unanswered. Helena had been watching Mrs. Pemberton's decline with professional interest, noting how the cancer ravaged her frail body while her spirit stubbornly refused to surrender. Helen approached bed 247 with the quiet grace that had made her legendary among the hospital staff. Mrs. Pemberton's eyes fluttered open as she sensed someone's presence, and she managed a weak smile when she recognized Helena's familiar face. Over the past few weeks, Helena had become Mrs. Pemberton's favorite nurse, always available with a kind word, a gentle touch, or an extra dose of pain medication when the night became unbearable. The old woman's voice was barely a whisper as she spoke. Her throat was dry and swollen, making each word an effort. She told Helena about the dreams she'd been having, visions of her late husband calling to her from a place where there was no pain, no suffering, only peace. Helena listened with apparent sympathy, nodding at appropriate moments and making soft sounds of comfort. Inside, she felt the familiar stirring of purpose that always came when a patient was ready for her special brand of care. Helena glanced at the clock on the wall. 3:15 a.m. Perfect timing, as always. She had developed this precise scheduling over years of practice, understanding that the early morning hours created the ideal conditions for her work. Hospital staff were at their drowsiest. Security was minimal, and the patients were typically in their deepest sleep cycles, except for those suffering from severe pain, like Mrs. Pemberton. From her pocket, Helena withdrew a small vial filled with a clear liquid. To anyone who might glimpse it, it appeared to be standard saline solution used for IV flushes. In reality, it contained a carefully prepared mixture of potassium chloride and insulin, a combination that would stop Mrs. Helena had perfected this particular formula through extensive research and careful experimentation. Medical textbooks, online resources, and her own observations had taught her exactly how much of each component was needed to ensure a quick, relatively peaceful death that would appear natural to any cursory examination. The beauty of her method lay in its simplicity and the fact that terminally ill patients were expected to die. No one questioned the exact timing or looked too closely at the specific cause. As Helena prepared the injection, she spoke to Mrs. Pemberton in soothing tones about the peace that awaited her on the other side. She described a place where pain no longer existed, where loved ones were reunited, and where suffering was transformed into eternal rest. Mrs. Pemberton's eyes filled with tears, Whether from gratitude, fear, or simply the morphine that clouded her judgment, Helena couldn't tell and didn't particularly care. The injection went smoothly into Mrs. Pemberton's IV port, the deadly mixture flowing silently into her bloodstream. Helena held the old woman's hand as the chemicals began their work, monitoring her pulse and breathing with professional detachment. Miss Pemberton's grip gradually weakened, her breathing became shallow, and her eyes took on the distant look that Helena had witnessed hundreds of times before. Helena spent the next few minutes creating the perfect scene of natural death. She dimmed the lights slightly, arranged Mrs. Pemberton's hands in a peaceful position, and even closed her eyes gently, a detail that families always seemed to appreciate. When the time came to call for the attending physician, Helena would display the appropriate level of professional sorrow while maintaining the composure expected of an experienced terminal ward nurse. The call to Dr. Martinez came at 3:25 a.m., giving Helena sufficient time to complete her preparations. When the doctor arrived to pronounce Mrs. Pemberton dead, he found Helena standing respectfully beside the bed, her expression conveying the perfect mixture of sadness and acceptance. Martinez had worked with Helena for years and trusted her judgment completely. If she said a patient had passed peacefully in their sleep, he had no reason to question her assessment. The paperwork was completed with efficient professionalism. Cause of death: complications related to metastatic pancreatic cancer. Time of death: 3:17 a.m. Helena filled out her nursing notes with practiced ease, describing Miss Pemberton's final hours in terms that painted a picture of natural decline and peaceful passing. Every detail was carefully crafted to support the narrative of a gentle death that had come as a blessing to end unbearable suffering. When Mrs. Pemberton's daughter arrived at the hospital the following morning, Helena was still on duty to provide comfort during the family's moment of grief. The woman wept as Helena described her mother's final hours, expressing gratitude that her mother had not suffered and that she had passed away so peacefully. Helena accepted the thanks with humble grace, mentioning how Mrs. Pemberton had spoken about her daughter with such love in her final moments. The daughter hugged Helena before leaving, thanking her for the care and compassion she had shown during such a difficult time. As Helena watched the grieving woman walk away, she felt the familiar sensation of satisfaction that always followed a successful intervention. Another soul had been spared unnecessary suffering. Another family had been given the gift of believing their loved one had died in peace, and Helena had once again fulfilled her sacred duty as an angel of mercy. Over the following days, Helena received commendations from the hospital administration for her exceptional care of Mrs. Pemberton and her family. Her supervisors noted her professionalism, her compassion, and her ability to provide comfort during the most challenging circumstances. Several colleagues mentioned how fortunate the hospital was to have such a dedicated nurse working in the terminal ward, where her skills and temperament were perfectly suited to the demanding environment. Helena accepted these compliments with appropriate modesty, but internally she felt a deep sense of pride in her work. Each successful intervention reinforced her belief that she was providing a necessary service that the medical establishment was too constrained by legal and ethical limitations to offer. She saw herself as operating in the gray areas where official medicine feared to tread, making the difficult decisions that others lacked the courage to face. The terminal ward had become Helena's domain, and she ruled it with quiet authority. Other nurses often deferred to her experience and judgment, particularly when dealing with difficult cases or distraught families. Her reputation for somehow making patients' final days more comfortable had spread throughout the hospital, leading to increased requests for her to be assigned to the most challenging cases. What her colleagues didn't realize was that Helena's success rate in making patients comfortable came from her willingness to ensure their suffering ended permanently rather than temporarily. While other nurses provided palliative care that merely managed symptoms, Helena offered the ultimate palliation, death itself, delivered with precision and disguised as natural causes. As her shift ended and the morning staff began arriving, Helena completed her final tasks with the same meticulous attention to detail that characterized all her work. She updated patient charts, briefed her replacement on each patient's condition, and prepared to return home for the day. To any observer, she appeared to be simply another dedicated healthcare professional finishing a long night of caring for society's most vulnerable members. But as Helena drove home through the quiet streets of the city, she was already thinking about tomorrow night's shift and which patients might be ready for her special form of intervention. The terminal ward held numerous possibilities, and Helena's trained eye could identify those who were suffering unnecessarily, whose families were enduring prolonged agony, and whose deaths could be transformed from prolonged suffering into gentle release. Her small apartment was decorated with thank you cards from grateful families, commendation letters from hospital administrators, and photographs of patients she had helped during their final days. To anyone who visited, it would appear to be the home of a nurse who took exceptional pride in her work and maintained deep emotional connections with her patients and their loved ones. In reality, it was the shrine of someone who had found her life's purpose in the systematic termination of human suffering through methods that the medical establishment would never officially sanction. Helena had created her own version of healthcare, one that acknowledged the reality that sometimes the most merciful treatment was no treatment at all, just a gentle push toward the inevitable conclusion that awaited everyone who entered her ward. As she prepared for sleep, Helena reflected on Mrs. Pemberton's peaceful death and felt the satisfaction that always came with a job well done. Tomorrow night would bring new opportunities to practice her art, new patients who might benefit from her unique approach to terminal care, and new families who would eventually thank her for the compassion and professionalism she displayed during their most difficult hours. The angel of mercy had claimed another soul, and no one suspected that mercy could be so deadly. Helena Nightshade had not always been a killer. The transformation from caring nurse to angel of death had been gradual, methodical, and in her mind entirely justified by the suffering she witnessed daily in St. Catherine's terminal ward. What began as a single act of what she called compassionate intervention had evolved into a sophisticated system of patient evaluation, selection, and termination that she had refined over 3 years of practice. The first time Helena had deliberately ended a patient's life, it had been almost accidental. Thomas Hartwell, a 47-year-old construction worker, had been dying from complications following a massive stroke that had left him paralyzed and unable to communicate. His wife visited daily, begging him to squeeze her hand, to give any sign that he was still present in his devastated body. Helena had watched this tragic scene play out for weeks, seeing the woman's hope slowly crumble as her husband's condition steadily deteriorated. The gratitude in his wife's eyes when Helena explained how Thomas had simply stopped struggling had been intoxicating. The woman had thanked Helena repeatedly for making his final moments comfortable, never suspecting that her husband's death had been deliberately orchestrated. That night, Helena had experienced a profound sense of fulfillment, unlike anything she had felt during her previous 12 years of conventional nursing. From that pivotal moment, Helena had begun developing what she privately called her selection criteria, a systematic method for identifying patients who would benefit from her special intervention. Age was another important factor in Helena's calculations. Elderly patients were ideal because their deaths were expected and rarely questioned extensively. Middle-aged patients required more careful consideration. Their deaths needed to appear clearly linked to their existing conditions to avoid unwanted scrutiny. Helena had learned to avoid younger patients entirely after an early mistake nearly exposed her activities when a 28-year-old's unexpected death triggered an automatic autopsy review. Helena's methods had evolved considerably from that first impulsive intervention. She had spent countless hours researching various substances and techniques that could induce cardiac arrest, respiratory failure, or other fatal conditions, while leaving minimal forensic evidence. Her nursing background provided legitimate access to medical literature and pharmaceutical references that detailed the precise mechanisms of various drugs and their effects on compromised systems. Calcium chloride remained her preferred method for most interventions. A concentrated injection directly into an IV line would cause rapid cardiac arrest in patients whose hearts were already stressed by illness or medication. The substance occurred naturally in the body, making it nearly impossible to detect in post-mortem examinations unless investigators were specifically looking for it, and terminal ward deaths rarely warranted such detailed scrutiny. For patients without IV access, Helena had developed alternative approaches. Insulin overdoses were particularly effective for diabetic patients, as the excessive insulin would cause fatal hypoglycemia that could easily be attributed to medication errors or the progression of their underlying condition. Air embolisms, introduced through existing IV lines or injection sites, could cause strokes or heart attacks that appeared entirely consistent with the patient's existing risk factors. Helena had also mastered more subtle techniques for patients who required gentler approaches. Morphine overdoses were virtually undetectable in terminal patients who were already receiving significant pain medication. A gradual increase in dosage over several days could bring about respiratory depression that would appear to be a natural progression of their condition. Families often praised Helena for keeping their loved ones comfortable during their final days, never realizing that the comfort came at the cost of their lives. The psychological aspects of patient selection had become increasingly important to Helena as her experience grew. She had learned to identify not just physical suffering but emotional and spiritual anguish that made death preferable to continued existence. Patients who spoke about wanting to go home or join deceased relatives were prime candidates. Those who had lost the will to fight their illness or who expressed envy of patients who had already died often found themselves receiving Helena's special attention. Helena's ability to read family dynamics had also become crucial to her success. Relatives who were clearly exhausted by prolonged caregiving were often grateful when their loved one's suffering finally ended, even if they couldn't admit it openly. Children who had been watching their parents deteriorate for months typically received the news of a peaceful death with relief mixed with their grief. Helena had become expert at identifying families who would be thankful for closure rather than suspicious about timing. The development of her techniques had required considerable experimentation and refinement. Helena's early interventions had been somewhat crude and occasionally resulted in deaths that appeared slightly unusual. Patients who died more quickly than expected or with symptoms that didn't perfectly align with their diagnoses. Each case had taught her valuable lessons about dosages, timing, and the importance of creating consistent patterns that matched natural disease progression. Helena's record-keeping had evolved into an elaborate system that served both practical and psychological purposes. She maintained detailed, unofficial notes about each intervention, recording the patient's condition, the method used, the family's reaction, and any complications or concerns that arose afterward. These records were written in a personal code and kept in a locked box in her apartment, representing both a trophy collection and a reference guide for future interventions. The official documentation that Helena completed as part of her nursing duties had become works of art in their own right. She crafted patient care notes that painted vivid pictures of natural decline, peaceful acceptance, and dignified death. Her descriptions of final moments were so moving that supervisors often used them as examples of compassionate end-of-life care documentation. Family members who requested copies of their loved ones' medical records frequently commented on how Helena's notes helped them understand and accept their loss. Helena's relationship with her colleagues had required careful management as her activities expanded. She had cultivated a reputation as the nurse who somehow made patients' final days more comfortable, without anyone questioning exactly how she achieved such remarkable results. Other staff members often requested her input on difficult cases, unknowingly asking for advice from someone who had perfected the art of hastening death while appearing to provide exceptional care. Helena had also developed relationships with key personnel in other departments who could provide useful information or assistance. The pharmacy staff trusted her completely, never questioning her requests for additional medications or her explanations for discrepancies in drug inventories. Laboratory technicians appreciated her attention to detail in collecting specimens and rarely questioned unusual patterns in patient test results that occurred after her interventions. The morgue attendants had come to know Helena well, as she often volunteered to perform the initial preparation of deceased patients from her ward. This additional responsibility allowed her to ensure that any physical evidence of her interventions was properly concealed and that the bodies appeared consistent with natural deaths from their documented conditions. Her thoroughness in this area had prevented several potential discoveries that might have raised uncomfortable questions. As Helena's confidence in her methods grew, she began taking more calculated risks with more complex cases. Patients with unusual conditions or complicated medical histories presented interesting challenges that tested her knowledge and creativity. She had successfully terminated a patient with a rare blood disorder by inducing complications that appeared consistent with the progression of his disease. Another intervention involved a woman with multiple organ transplants, whose death was attributed to rejection reactions that Helena had artificially triggered. The intellectual stimulation of these challenging cases had become an important part of Helena's motivation. Each successful intervention felt like solving a complex puzzle, requiring her to consider multiple variables and execute precise solutions under pressure. The medical knowledge she had acquired through years of study and practice was finally being applied to its fullest potential, even if the application fell well outside conventional ethical boundaries. Helena's understanding of hospital politics had also become crucial to maintaining her freedom to operate. She had identified which physicians were most likely to accept her assessments without question, which administrators valued her contributions highly enough to overlook minor irregularities, and which colleagues could be trusted to support her version of events if questions ever arose. This network of unwitting allies provided multiple layers of protection for her activities. More importantly, Helena's success in her role had led to increasing autonomy in her work assignments. Supervisors trusted her judgment completely when it came to patient care decisions, medication management, and family communication. This freedom allowed her to operate with minimal oversight, making her interventions easier to plan and execute without interference from colleagues who might ask inconvenient questions. The psychological satisfaction Helena derived from her work had grown more complex over time. The initial gratification of ending suffering had evolved into a deeper sense of purpose and power. She had become the arbiter of life and death for dozens of patients, making decisions that their doctors were too constrained by professional ethics to consider. In her mind, she was providing a service that society needed but was too hypocritical to acknowledge openly. Helena's view of her role had transformed from that of a conventional nurse to something approaching a sacred calling. She saw herself as operating in the space between official medicine and natural death, facilitating transitions that would otherwise be prolonged and agonizing. The gratitude of families, the recognition from colleagues, and the peaceful death she orchestrated all reinforced her belief that her work served a higher purpose than conventional healthcare. As Chapter 2 of Helena's story reached its conclusion, her methods had become refined to near perfection. She had developed reliable techniques for various types of patients, established systems for avoiding detection, and created a professional reputation that provided cover for her activities. The foundation was set for the expansion of her operations and the eventual challenges that would test her carefully constructed facade. The angel of death had perfected her craft, but the true test of her abilities was yet to come. Helena Nightshade's activities at St. Catherine's Hospital had entered what she privately considered her golden period, a time when her reputation as an exceptional nurse provided perfect cover for an increasingly ambitious expansion of her mercy killings. Over 18 months, her unofficial body count had reached 63 patients, each death carefully orchestrated to appear natural while providing Helena with the psychological satisfaction of controlling life and death with godlike precision. The terminal ward had become Helena's personal kingdom, where her word carried weight that even senior physicians rarely questioned. When Helena suggested that a patient was ready for comfort care only, doctors typically agreed without extensive discussion. When she recommended discontinuing aggressive treatments in favor of letting nature take its course, families found her guidance both compassionate and medically sound. What they didn't realize was that Helena's version of nature often required pharmaceutical assistance to reach its inevitable conclusion. Helena's patient selection process had evolved into an art form that balanced risk management with psychological gratification. She had developed an elaborate scoring system that evaluated potential victims based on multiple criteria: severity of illness, family dynamics, likelihood of autopsy, and what she called spiritual readiness for transition. Patients who scored highest on her private assessment became candidates for immediate intervention, while those with lower scores were monitored for changes that might improve their eligibility. The scoring system had emerged from Helena's growing need to justify her selections through seemingly objective criteria. A patient with terminal cancer, supportive family members, and expressed wishes to stop fighting might score a perfect 10 on Helena's scale. Someone with a questionable diagnosis, difficult relatives, or strong will to live would score much lower and typically receive conventional care until their circumstances changed. This methodical approach helped Helena maintain the illusion that her choices were based on medical judgment rather than personal preference. Helena's techniques had also become more sophisticated and varied as she gained experience with different types of cases. She had perfected what she called her signature methods, approaches that had proven consistently effective while leaving minimal evidence. The potassium chloride injection remained her standard technique for patients with IV access, but she had developed backup methods for various scenarios that might require alternative approaches. For patients without intravenous lines, Helena had mastered the insulin overdose technique that mimicked diabetic complications. A carefully calculated injection of regular insulin would cause fatal hypoglycemia within hours, particularly in patients whose nutritional status was already compromised by illness. The beauty of this method lay in its simplicity. Insulin was a common medication in hospital settings, and hypoglycemic episodes were expected complications in diabetic patients with serious illnesses. Air embolism had become another reliable technique for specific situations. A small amount of air introduced into an IV line or central catheter could cause stroke-like symptoms or cardiac arrest that appeared completely consistent with the patient's existing risk factors. Helena had practiced this technique until she could introduce precisely the amount of air needed to cause fatal complications without creating obvious evidence of deliberate intervention. Helena's most innovative development had been what she called cascade failures. Interventions that triggered a series of medical complications that ultimately led to death through apparently natural progression. By slightly altering medication dosages, adjusting IV flow rates, or modifying respiratory support settings, she could initiate downward spirals that appeared to be unfortunate but inevitable consequences of the patient's underlying condition. The psychological aspects of Helena's work had become increasingly important as her activities expanded. She had developed remarkable skill in reading patient and family emotions, identifying the optimal moments for intervention when death would be received as a blessing rather than a tragedy. Timing had become crucial too early, and families might question why their loved one died suddenly. Too late, and the patient might suffer unnecessarily while Helena waited for the perfect opportunity. Helena's relationship with families had evolved into sophisticated psychological manipulation designed to prepare them for their loved one's death while ensuring their gratitude for Helena's care. She had learned to plant subtle suggestions about the patient's declining condition, the futility of continued treatment, and the peaceful nature of letting go when the time was right. Families often felt that Helena had helped them reach difficult decisions about end-of-life care, never realizing that she had orchestrated both the circumstances and their emotional responses. Sarah's first few weeks on the ward had been marked by enthusiasm that Helena found both amusing and potentially problematic. The young nurse threw herself into patient care with dedication that impressed supervisors and endeared her to families, but also meant that she paid closer attention to patient conditions and treatment outcomes than Helena preferred. Sarah asked questions about medication protocols, requested explanations for treatment decisions, and seemed genuinely puzzled by some of the patterns she observed in patient outcomes. Helena's initial strategy for managing Sarah had been to position herself as a mentor and guide, offering to share her experience and help the newcomer adjust to the emotional challenges of terminal care. This approach served dual purposes. It allowed Helena to monitor Sarah's observations and concerns while establishing the kind of trusting relationship that would make the younger nurse less likely to question Helena's professional judgments. The mentoring relationship had proceeded smoothly until Sarah began noticing statistical anomalies in their ward's patient outcomes. During a casual conversation in the break room, Sarah had mentioned that she was surprised by how many patients seemed to die during the night shift, particularly during Helena's scheduled duty periods. She wondered aloud whether there might be environmental factors, lighting, noise levels, or staff-to-patient ratios that contributed to increased mortality during certain hours. Helena had responded to Sarah's observations with apparent interest and concern, suggesting that the correlation was probably related to the natural circadian rhythms that affected critically ill patients. She explained that many biological processes reach their lowest points during early morning hours, making patients most vulnerable to complications between 2 a.m. Sarah had accepted this explanation, but Helena noticed that the younger nurse continued to pay attention to timing patterns in ways that could eventually become problematic. More troubling had been Sarah's tendency to stay late after her shifts to spend additional time with patients who seemed to be declining rapidly. On several occasions, Sarah's unexpected presence had forced Helena to postpone planned interventions, disrupting carefully timed operations and creating the need for alternative approaches. Helena began to realize that Sarah's dedication, while admirable in conventional terms, posed a significant threat to the continuation of her activities. Helena's concern about Sarah had intensified when the young nurse began asking specific questions about certain patients' deaths. Sarah had been particularly troubled by the case of Margaret Foster, a 68-year-old woman with lung cancer who had seemed relatively stable before dying suddenly during one of Helena's shifts. Sarah had expected Mrs. Foster to live for at least several more weeks based on her condition earlier that day, and she couldn't understand why the woman's deterioration had been so rapid and unexpected. Helena had provided detailed explanations about the unpredictable nature of cancer progression and the way that patients could experience sudden declines without warning signs. She had shown Sarah medical literature about the phenomenon of failure to thrive in terminal patients and explained how emotional factors could accelerate physical decline in ways that weren't immediately apparent to medical staff. Sarah had seemed satisfied with these explanations, but Helena noticed that she began paying even closer attention to patient conditions and outcomes. The situation with Sarah had reached a critical point when the young nurse discovered a discrepancy in medication records that could potentially expose Helena's activities. While reviewing charts for a quality assurance project, Sarah had noticed that several patients who died during Helena's shifts had received unusually large doses of pain medication in their final hours, despite having stable pain management regimens earlier in their admissions. Sarah had approached Helena privately with her concerns, suggesting that there might be a systematic error in medication documentation or administration that needed to be addressed. She was clearly worried about patient safety and quality of care rather than suspecting deliberate wrongdoing, but her discovery represented a serious threat to Helena's operations that required immediate attention. Helena's response to Sarah's discovery had been a masterpiece of misdirection and manipulation. She had expressed gratitude for Sarah's diligence and concern, explaining that the medication patterns Sarah had identified were actually evidence of Helena's advanced pain management techniques. She described how she had developed methods for providing superior comfort care by carefully titrating medications to achieve optimal pain relief during patients' final hours, approaches that weren't widely understood by less experienced nurses. Helena had offered to teach Sarah these advanced techniques, framing the conversation as an opportunity for professional development that would help the younger nurse provide better care to suffering patients. She had provided Sarah with medical journals and continuing education materials about palliative care innovations, effectively burying the evidence of her killing methods within legitimate discussions of end-of-life treatment protocols. The educational approach had successfully deflected Sarah's concerns while providing Helena with opportunities to monitor the younger nurse's continued observations. However, Helena had realized that Sarah's natural curiosity and analytical mind made her a long-term threat that would eventually need to be addressed more definitively. The young nurse's combination of intelligence, dedication, and moral conviction created a profile that matched Helena's criteria for intervention, albeit for entirely different reasons than her usual patient selections. Helena's decision to eliminate Sarah had not been made lightly, as targeting a healthy colleague presented significantly greater risks than her usual patient interventions. The medication room provided the perfect setting for Helena's plan, as it offered privacy while containing legitimate reasons for Sarah to be handling potentially dangerous substances. Helena had prepared a syringe containing a lethal dose of concentrated potassium chloride, disguised as medication that Sarah would supposedly be preparing for a patient who was experiencing cardiac complications. The injection had been administered quickly and efficiently, causing Sarah to collapse within seconds as the potassium chloride disrupted her cardiac rhythm. Helena had immediately begun CPR while calling for emergency assistance, creating the appearance of a medical emergency rather than an assault. When the code team arrived, they found Helena performing chest compressions on Sarah, apparently making every effort to save her colleague's life. Sarah's death had been attributed to a rare cardiac arrhythmia that sometimes affected young adults without warning signs or risk factors. The autopsy had revealed elevated potassium levels, but these were explained as a result of the resuscitation efforts and the medications administered during the unsuccessful attempt to restart her heart. Helena's emotional response to losing her mentee had been particularly convincing, earning sympathy from colleagues who admired her dedication to training new nurses. The aftermath of Sarah's death had actually strengthened Helena's position within the hospital community. Her colleagues viewed her as someone who had experienced personal loss while maintaining professional composure, and administrators recognized her commitment to staff development even in the face of tragedy. The ward's other nurses looked to Helena for leadership during the difficult period of adjustment to losing a promising team member. Helena's patient interventions had continued without interruption following Sarah's elimination, though she had become more cautious about accepting new staff members who might possess similar analytical abilities. Her selection criteria for both patients and potential threats had been refined to account for lessons learned from the Sarah incident, improving her operational security while expanding her capabilities. The psychological impact of killing a healthy colleague had been different from Helena's usual patient interventions, providing a new type of satisfaction that came from successfully managing a complex threat to her operations. Sarah's death had demonstrated Helena's ability to adapt her methods to different types of targets, expanding her skill set beyond mercy killings to include protective eliminations when necessary. As Chapter 3 concluded, Helena's collection of victims had grown to include not only suffering patients but also anyone who threatened to expose her activities. Her transformation from mercy killer to comprehensive predator was complete, setting the stage for even greater challenges to her carefully constructed facade of professional excellence. The Angel of Death had eliminated her first threat, but greater challenges awaited in the shadows of St. Catherine's Hospital. The statistical anomaly that would eventually expose Helena Nightshade's 3-year killing spree began as a routine quality assurance review conducted by Dr. Marcus Wilson, the hospital's new chief of internal medicine. Dr. Wilson had been hired specifically to improve St. Catherine's patient care metrics and had spent his first 6 months implementing systematic reviews of treatment outcomes across all departments. What he discovered in the terminal ward's mortality data would challenge everything he thought he knew about natural death patterns and hospital safety protocols. Dr. Wilson's background made him uniquely qualified to recognize the subtle patterns that had escaped notice for so long. His previous position at Johns Hopkins had involved extensive research into hospital mortality statistics, and he had published several papers on identifying systemic factors that influenced patient outcomes. When he applied his analytical expertise to St. Catherine's data, the results were both fascinating and deeply disturbing. The numbers told a story that seemed almost impossible to believe. The terminal ward's mortality rate during night shifts was 23% higher than during day shifts, with a particularly dramatic spike between 3. More significantly, patient deaths during Helena Nightshade's scheduled shifts occurred at rates that were statistically impossible to explain through random chance or normal variations in patient acuity. Dr. Wilson's initial assumption had been that the data reflected some environmental factor unique to the night shift environment. Perhaps patients were more vulnerable during certain hours due to circadian rhythm disruptions, or maybe staffing patterns during overnight periods affected the quality of care. He had spent weeks exploring these possibilities, consulting with sleep medicine specialists and reviewing research on chronobiology in terminal patients. However, as Dr. Wilson dug deeper into the data, more troubling patterns emerged. The deaths occurring during Helena's shifts were not only more frequent, but also followed unusual timing patterns that suggested something other than natural progression of terminal illnesses. Patients who had been stable for days or weeks were dying suddenly during single overnight periods, often with minimal documentation of declining conditions in the hours before their deaths. The medication records associated with these deaths presented another anomaly that caught Dr. Wilson's attention. Patients who died during Helena's shifts consistently received higher doses of pain medications and other controlled substances in their final hours, despite having stable medication requirements throughout their admissions. The increases appeared to be medically justified based on the nursing notes, but the frequency and magnitude of these adjustments exceeded what would be expected in a normal patient population. Dr. Wilson's concerns had been heightened when he discovered that several patients who died during Helena's care had shown signs of improvement or stabilization just hours before their deaths. Medical records indicated that these patients had been responding positively to treatment, had stable vital signs, and had even expressed optimism about their prognosis to family members during evening visiting hours. Their sudden deterioration and death during overnight shifts seemed inconsistent with their documented clinical trajectories. The investigation had taken a more serious turn when Dr. Wilson consulted with Dr. Patricia Hernandez, the hospital's chief medical examiner, about the unusual patterns he had identified. Hernandez had her own concerns about certain deaths that had occurred in the terminal ward, though she had attributed them to the natural unpredictability of terminal illness rather than suspecting deliberate intervention. Dr. Hernandez revealed that she had noticed an unusual number of cardiac deaths among terminal ward patients, particularly during night shifts. While cardiac complications were expected in seriously ill patients, the specific patterns of heart rhythm abnormalities seemed more consistent with electrolyte imbalances or drug interactions than with natural disease progression. However, the patient's terminal diagnoses and advanced ages had made detailed investigation seem unnecessary. The collaboration between Dr. Wilson and Dr. Hernandez had led to a systematic review of death certificates and autopsy reports for patients who had died in the terminal ward over the previous 3 years. This analysis revealed additional anomalies that strengthened their suspicions about unnatural deaths occurring during specific shifts. Blood chemistry abnormalities, particularly elevated potassium levels, appeared more frequently in patients who died during Helena's care than in other terminal ward deaths. Dr. Wilson's investigation had been conducted with extreme discretion, as the implications of his findings could destroy careers and expose the hospital to massive liability if his suspicions proved correct. He had shared his concerns only with Dr. Hernandez and the hospital's chief administrator, Patricia Morrison, who had authorized a covert investigation to gather additional evidence before involving law enforcement. The covert investigation had involved several strategies designed to monitor Helena's activities without alerting her to the scrutiny she was receiving. Security cameras in the terminal ward were repositioned to provide better coverage of patient rooms and medication preparation areas. Electronic monitoring systems were enhanced to track medication dispensing and patient access more precisely. Most importantly, Dr. Wilson arranged to have several trusted colleagues rotate through temporary assignments in the terminal ward to observe nursing practices firsthand. Dr. Jennifer Hayes, a critical care physician with extensive experience in terminal patient management, had been the first observer assigned to monitor Helena's activities. Dr. Hayes worked several overnight shifts alongside Helena, ostensibly to gain experience in palliative care techniques. Her observations had been both revealing and disturbing, documenting behaviors that seemed inconsistent with standard nursing practices. Dr. Hayes noted that Helena demonstrated unusual patterns in her patient assessments, spending significantly more time with certain patients while seeming to avoid others without clear medical rationale. Helena's documentation practices were meticulous, but her patient care notes contained subtle inconsistencies that suggested she might be crafting narratives to support predetermined outcomes rather than objectively recording clinical observations. Most concerning to Dr. Hayes had been Helena's medication handling practices. While Helena followed proper protocols for accessing and preparing medications, she demonstrated knowledge of drug interactions and dosing calculations that seemed unusually sophisticated for a bedside nurse. Helena also showed familiarity with medications that were rarely used in the terminal ward, suggesting that she had been researching pharmaceutical interventions beyond those typically required for her patients. The investigation had reached a critical juncture when Helena began targeting patients who were not genuinely terminal, expanding her selection criteria to include individuals whose deaths would be more difficult to explain as natural outcomes. Wilson's analysis revealed that several recent deaths had involved patients whose prognosis had been guardedly optimistic rather than hopeless, suggesting that Helena's criteria for intervention were evolving in dangerous directions. One particularly troubling case involved Robert Chen, a 54-year-old man who had been admitted with complications from diabetes, but whose condition had been improving steadily under treatment. Another suspicious case had been Maria Santos, a 47-year-old woman recovering from surgery to remove a brain tumor. While her prognosis had been uncertain, she had been neurologically stable and had been communicating normally with her family just hours before her death. The massive stroke that killed her during Helena's shift was medically possible, but occurred at a frequency that was statistically anomalous when combined with other similar cases. Helena's confident demeanor during these increasingly suspicious deaths had actually strengthened Dr. Wilson's suspicions about her involvement. Rather than showing the emotional distress that would be expected from a nurse experiencing an unusual number of patient losses, Helena had maintained her professional composure while expressing appropriate sympathy for the families. Her ability to provide comfort and explanations during these difficult situations seemed almost rehearsed, as if she had extensive practice managing such scenarios. The breakthrough in the investigation had come when Dr. Wilson discovered that Helena had been systematically accessing medical records and research databases to study conditions and treatments far beyond those required for her assigned patients. Computer logs revealed that Helena had been researching cardiac medications, insulin protocols, and emergency resuscitation procedures during her off-duty hours, suggesting that she was educating herself about topics directly related to the suspicious deaths. More damning evidence emerged when Dr. Wilson's team discovered that Helena had been ordering medications and supplies that were not typically used in the terminal ward. Purchase records showed that Helena had requested access to concentrated electrolyte solutions, high-dose insulin preparations, and specialized syringes that would be useful for precise medication administration, but were rarely needed for routine terminal care. The investigation had also revealed that Helena had been manipulating work schedules to ensure that she was present during the final hours of specific patients' lives. She had traded shifts, worked voluntary overtime, and requested specific patient assignments with a frequency that suggested she was orchestrating opportunities for intervention rather than simply responding to staffing needs. Dr. Wilson's team had identified a pattern of Helena volunteering for the most challenging cases, patients whose deaths would be expected and whose families would be grateful for compassionate care during their final hours. This pattern suggested sophisticated planning rather than random assignment, indicating that Helena was actively selecting her victims based on criteria that would minimize suspicion while maximizing her opportunities for intervention. The psychological profile that emerged from the investigation painted a picture of someone who had evolved from a caring nurse into a predator who used medical knowledge and institutional trust to satisfy personal needs for control and recognition. Helena's reputation as an exceptional nurse had provided perfect cover for activities that were antithetical to everything the nursing profession represented. As the investigation neared its conclusion, Dr. Wilson faced the difficult decision of how to proceed with evidence that suggested one of the hospital's most respected nurses had been systematically murdering patients for years. The legal and professional implications were staggering, but the ethical obligation to protect future patients made action inevitable. Helena remained unaware of the investigation closing around her, confident in the protection provided by her sterling reputation and the genuine gratitude of families whose loved ones had died under her care. She continued her activities with the same methodical precision that had characterized her work for 3 years, selecting new victims and planning interventions with the expertise she had developed through extensive practice. The stage was set for a confrontation between Helena's carefully constructed facade and the mounting evidence of her true nature. Wilson's investigation had provided the foundation for exposing crimes that had been hidden in plain sight for years, protected by institutional trust and the assumption that respected healthcare professionals could not be capable of such systematic betrayal. Helena Nightshade had always prided herself on her ability to read situations and adapt to changing circumstances, but the subtle signs that should have warned her of impending exposure had been filtered through 3 years of supreme confidence in her invulnerability. The investigation that Dr. Marcus Wilson had been conducting for months was closing in around her like a carefully woven net. Yet Helena remained focused on what she believed would be her greatest triumph, a final intervention that would demonstrate the ultimate expression of her mercy. The patient who had captured Helena's attention for her culminating masterpiece was Dr. Wilson himself. The irony was exquisite in Helena's mind. The very man who had been scrutinizing her work would become the subject of her most sophisticated intervention. Wilson had been admitted to the hospital following a minor cardiac episode during a late-night research session, and his placement in the terminal ward for observation had seemed like divine providence to Helena. Helena had volunteered immediately to serve as Dr. Wilson's primary nurse, expressing concern for a colleague who had been working too hard and needed careful monitoring during his recovery. The administration had praised Helena's dedication and professionalism, never suspecting that she was positioning herself to eliminate the greatest threat to her continued activities. Dr. Wilson's condition was not serious. Stress-induced arrhythmia that should have resolved within days with proper rest and medication. However, Helena had begun documenting subtle changes in his status that painted a picture of someone whose cardiac condition was more precarious than initially apparent. The beauty of Helena's plan lay in its simplicity and the poetic justice she believed it represented. Dr. Wilson would suffer a massive heart attack during the early morning hours, apparently triggered by the stress of his hospitalization and his underlying cardiac vulnerability. Helena had researched his medical history extensively, identifying risk factors and previous episodes that would make his death appear to be a tragic but unsurprising outcome. Helena's preparation for Dr. Wilson's termination had been more meticulous than any of her previous interventions. She had calculated precisely the dose of potassium chloride needed to stop his heart while accounting for his body weight, existing medications, and cardiac status. What Helena didn't realize was that her every move had been under surveillance for weeks. Dr. Wilson's admission to the terminal ward had been carefully orchestrated to provide the final evidence needed to expose her activities. Hidden cameras recorded her interactions with Wilson, her access to medications, and her preparation of syringes during overnight shifts. Electronic monitoring systems tracked her every movement through the hospital corridors. The night of Helena's planned intervention began like dozens of others over the past 3 years. She arrived for her shift with the same professional demeanor that had made her legendary among the hospital staff, greeting colleagues with warm smiles and expressing appropriate concern for her patients' welfare. Her interaction with Dr. Wilson was particularly solicitous, as she explained her plans to monitor him closely throughout the night and ensure his comfort during what she implied might be a critical period in his recovery. At 3:15 a.m., Helena approached Dr. Wilson's room with the syringe concealed in her uniform pocket. Her pulse was steady, her breathing controlled, and her movements confident as she prepared to administer what she believed would be her masterpiece of mercy. Wilson appeared to be sleeping peacefully, unaware that his researchers' curiosity about statistical anomalies was about to be permanently satisfied. Helena's surprise was complete when Dr. Wilson opened his eyes as she reached for his IV line. He had been awake for hours, waiting for the moment when Helena would reveal her true nature. Security personnel emerged from concealment positions throughout the room, while Dr. Hernandez and other medical staff entered to witness Helena's final moments as a trusted member of the healthcare community. The syringe in Helena's hand contained enough potassium chloride to kill Dr. Wilson within minutes, providing irrefutable evidence of her murderous intent. Her calm reaction to being caught in the act was perhaps the most chilling aspect of the entire confrontation. Helena showed no surprise, fear, or remorse, only a slight disappointment that her plan had been disrupted. Helena's first words to her captors revealed the depth of her delusion and the twisted logic that had driven her actions for 3 years. She expressed regret that Dr. Wilson would now have to endure the prolonged suffering that she had been trying to spare him. explaining that his cardiac condition would inevitably worsen and cause significant pain for both him and his family. In her mind, she was still providing mercy, even as she was being arrested for attempted murder. The interrogation that followed Helena's arrest revealed the full scope of her activities and the sophisticated methods she had developed to avoid detection. Helena spoke openly about her techniques, her selection criteria, and her motivation, displaying no understanding that her actions constituted criminal behavior rather than advanced nursing practice. She described her interventions as compassionate care that the medical establishment was too constrained by legal and ethical limitations to provide. The investigation that followed Helena's arrest expanded to include a comprehensive review of every death that had occurred during her shifts over the previous 3 years. Forensic experts re-examined medical records, interviewed family members, and conducted additional testing on preserved tissue samples to confirm the true causes of death. The scope of Helena's crimes exceeded even Dr. Wilson's most pessimistic estimates. The legal proceedings against Helena became a landmark case in medical serial killing, with prosecutors presenting evidence of systematic murder that had been concealed within the framework of legitimate healthcare. Helena's defense team attempted to argue that she had been providing end-of-life care rather than committing murder, but the evidence clearly showed that many of her victims had not been terminal and could have recovered with proper treatment. The families of Helena's victims experienced a complex range of emotions upon learning that their loved ones had been murdered rather than dying naturally. Many had been grateful for Helena's compassionate care and had found comfort in her explanations of peaceful deaths. The medical community's response to Helena's case led to significant changes in hospital oversight procedures, medication tracking systems, and staff monitoring protocols. St. Catherine's Hospital implemented comprehensive reforms designed to prevent similar cases, while medical schools revised their curricula to include training on identifying and reporting suspicious colleague behavior. The sentencing phase of Helena's trial provided an opportunity for victims' families to confront the woman who had killed their loved ones while accepting their thanks for her compassionate care. Many family members described the additional trauma of learning that their grief had been manipulated by the very person responsible for their loss. Helena listened to their statements with the same calm detachment she had displayed throughout the proceedings. Helena's final statement to the court revealed that her delusions remained intact despite the overwhelming evidence of her crimes. She continued to maintain that her actions had been motivated by compassion and that she had provided merciful deaths to patients who would otherwise have suffered unnecessarily. She expressed regret only that legal constraints would prevent other healthcare providers from offering similar services to patients in need. The judge's sentence reflected both the severity of Helena's crimes and the breach of trust she had committed against the medical profession and society. Multiple life sentences without possibility of parole ensured that Helena would never again have the opportunity to harm patients or exploit the trust placed in healthcare providers. The judge's comments emphasized the particular horror of crimes committed by those in positions of healing and care. Helena's incarceration marked the end of her 3-year reign as the self-appointed angel of death, but her legacy continued to influence medical practice and patient safety protocols. Her case became a cautionary tale taught in medical schools and nursing programs, illustrating how professional credentials and institutional trust could be exploited to commit systematic murder. In her prison cell, Helena maintained detailed journals describing her techniques and philosophies, apparently hoping that future healthcare providers might learn from her experience and continue her work. Prison psychologists who evaluated her found no evidence of mental illness or diminished capacity. Helena's actions had been the result of deliberate choices made by someone who understood the consequences but believed her personal moral framework superseded legal and professional constraints. The families of Helena's victims eventually filed civil lawsuits against St. Catherine's Hospital, arguing that inadequate oversight and monitoring had enabled her crimes to continue for years. The settlements reached in these cases led to significant improvements in patient safety protocols and staff supervision procedures throughout the healthcare system. Helena's story served as a reminder that the power to heal could be perverted into the power to harm when placed in the hands of someone whose moral compass had been corrupted by personal needs and delusions of grandeur. The trust that society placed in healthcare providers required constant vigilance and systematic safeguards to prevent its abuse by those who would exploit vulnerable patients for personal satisfaction. The angel of death had finally been grounded, her wings clipped by the same analytical mind she had sought to silence. Helena Nightshade's 3-year reign of terror had ended, but her crimes would continue to influence medical practice and patient safety measures for generations to come. The final mercy had been denied, and justice had been served to someone who had perverted the healing arts into instruments of systematic murder. In the end, Helena's greatest miscalculation had been her belief that statistical anomalies would go unnoticed in an age of data analysis and quality assurance. The very method she had used to avoid detection had created patterns that revealed her crimes to someone with the expertise to recognize them. The angel of mercy had become the victim of her own methodical precision, caught by the mathematical certainty of her own systematic approach to murder.